Hi everyone, welcome back to Dento'ZEN. Today we are here with a new video on the topic Ameloblastoma, which is a type of odontogenic tumor. Odontogenic means it arises from tooth-forming tissues. So in this video we are going to discuss introduction, definition, pathogenesis, clinical features, radiographic features, histopathological features, histopathological types which sometimes can be asked as short note, treatment and prognosis of ameloblastoma. So before we begin, I want you to quickly subscribe to Dento'ZEN if you have not done that till now. Also hit on the bell icon so that you remain notified about new videos. So ameloblastoma is odontogenic tumor, that is, it is arising from tooth-forming tissues. During tooth development, enamel organ first forms bud-shaped structure, later it turns into cap-shaped structure, and then it forms bell-shaped structure, which will form Hartwig's epithelial root sheath, the remnants of which are known as cell rest of Malassez. Remnants of dental lamina are known as cell rest of Serrae. So from these remnants, the ameloblastoma will arise. So it is arising from odontogenic epithelium. Epithelium. Why I am stressing on the word epithelium? Because there are certain odontogenic tumors which can arise from dental follicle, which is a type of odontogenic mesenchyme. Some odontogenic tumors can arise from both odontogenic epithelium and odontogenic mesenchyme. So the classification of odontogenic tumors will be taken in separate video. But for here, you can remember that ameloblastoma is arising from the odontogenic epithelium. So amongst all the odontogenic tumors, ameloblastoma is the second most common odontogenic tumor. That can be your final question. So which one is the most common odontogenic tumor then? These are the odontomas, and that can be your another viva question. But you know, ameloblastoma is more popular. Why? Because of its clinical behavior. Though it is a benign tumor, it grows slowly, but it is locally invasive tumor, because of which clinically it becomes the most significant odontogenic tumor. Now, Malassez in 1885 coined the term adamantinoma. Adamant means hard. Like in normal tooth development, there is hard tissue formation in enamel, dentine, and cementum. But in ameloblastoma, there is no hard tissue formation. So Churchill suggested an alternative term in 1934, ameloblastoma. So that can be your entrance question. Who gave the term ameloblastoma? Churchill. Another viva question can be, what are the other names for ameloblastoma? It can be called adamantinoma, adamantoblastoma, and multilocular cyst. Now we come to the definitions. There are two definitions. So the first definition says that it is a true neoplasm of enamel organ type tissue. Enamel organ in which ameloblast cells are there, in which stellate reticulum cells are there. Normally forms tooth, that is hard tissues, that is enamel, dentine, and cementum. But when it forms tumor, that is ameloblastoma, the cells lack inductive capacity, that is, they cannot give signals, so they cannot function properly, they cannot form hard tissue. So that is the definition. It is a true neoplasm of enamel organ type tissue which does not undergo differentiation to the point of enamel formation. So that is important for your entrance. The tumor in which cells lack inductive capacity is ameloblastoma. Now for your viva, your examiner may keep on insisting, tell me the second definition. So this second definition, which was given by Robinson, says that it is a tumor that is usually unicentric. Uni means single center. Non-functional cells are not functioning properly. Intermittent in growth, that is, it will not grow continuously. It will grow, will stop, will grow again. Anatomically benign, that is, microscopically if we look at the cells, they will not show atypical features. And clinically persistent, clinically the tumor will be there. So Huana unique tumor, so it is uniac, that is unicentric, non-functional, intermittent in growth, anatomically benign and clinically persistent. Now one important thing that you have to remember here is U in uniac is not unicystic, it is unicentric. So don't do that mistake. Please remember that for your viva. Now we come to the pathogenesis. So it is arising from remnants of dental lamina, that is cell rest of Serrae, remnants of Hartwig's epithelial root sheath, that is cell rest of Malassez. Second is, it can also arise from the epithelium of odontogenic cysts, especially the dentigerous cyst. When we read about dentigerous cyst, we read that there one complication of dentigerous cyst can be development of ameloblastoma in its epithelium. Disturbances in the developing enamel organ can also lead to ameloblastoma. Then the cells of the surface epithelium can also give rise to ameloblastoma. Then heterotropic epithelium, hetero means different, occurring in the other parts of the body, especially pituitary gland. So these are the 5 origins in the pathogenesis of ameloblastoma. But you know, current concept suggests that there are gene mutations in the cells which are pre-programmed for tooth development, which leads to ameloblastoma. And even there are certain factors which are responsible for invasion in this tumor. These are matrix metalloproteinesis 2, 8, 9. That is important for your entrance. Then environmental factors and individual patient variables like general health of the patient can also play a role. Though exact cause is not known, but certain predisposing factors have been given which predispose the patient to develop ameloblastoma. These can be trauma, infections, sites of previous inflammation, extraction of the teeth or early removal of the teeth, and dietary or nutritious factors. Now we come to the clinical types. There are 3 clinical types because these 3 behave differently, so they are described in 3 types. Now they are also suggested sometimes as clinico-radiological situations. Now first type is conventional solid or multicystic type. As the word says, that tumor cells grow as a solid mass, or within this solid mass we can see multiple cystic spaces. So this is the most common type, 86% of the cases, and it occurs within the jaws, within the bone. So it is the intraosseous type. Second is the unicystic, which comprises 13% of the cases. As the word says, so it grows as single cystic cavity. Now this one is also intraosseous, that is growing within the bones. But this is different from solid type because its recurrence rate is less and it has better prognosis. Then the third type is peripheral. As the word says, peripheral, it is in the periphery. Where in the periphery? In the soft tissues, that is outside the bone, extraosseous. So this is arising in the mandibular gingiva, which is the most common site, and it comprises 1% of the tumors. It is also different from solid type because its recurrence rate is also less and it is not invading like the solid ameloblastoma. Now there is another classification in which first three types remain the same, but a fourth type has been added, that is known as desmoplastic. Later in the video we'll see why it is added here, but for now you can remember that multicystic or solid type comprises 91% of the cases, unicystic type comprises 6% of the cases, peripheral type comprises 3% of the cases, and desmoplastic type comprises 1% of the cases according to this classification. Now we come to two important terms, craniopharyngioma. Now this is a tumor which is occurring outside the jaws. It is occurring in the central nervous system. It looks similar to ameloblastoma. It is also known as pituitary ameloblastoma. It can cause the destruction of the pituitary gland. It is also known as Rathke's pouch tumor because it is thought to be originating from this structure, that is Rathke's pouch, which give rise to craniopharyngeal duct, and the remnants of craniopharyngeal duct can give rise to this tumor. So this is known as Rathke's pouch tumor. Now another type of ameloblastoma which can occur outside the jaws is known as adamantinoma of the long bones bed, because it can occur in the long bones like femur, tibia, fibula. So it superficial resemblance to ameloblastoma of the jaws, but it is not related. So you have to remember these two here. Now we come to the clinical features. Now unicystic type and peripheral type will be taken in separate videos because they have different behavior. Here we are going to talk about the multicystic or the solid type mostly. So it occurs over wide age range. Most of the cases are seen in 20 to 60 years of age. Now average age at diagnosis is 33 to 39 years. Here you get your important entrance question. What is the mean age of ameloblastoma? It is that 33 years. Now equal gender predilection is seen and 10% cases can occur in children. If we talk about the race, some studies says it is more in blacks, others says that greater incidence is seen in Asians, so there are conflicting evidences. Now if we talk about the site, the most common site is mandible. More than 80% cases are seen in mandible, and that too in the posterior mandible. So 70% of the cases occur in molar angle ramus area, which is 3 times more than the premolar and anterior region. So that is important for your entrance. The most common site is the posterior mandible. So if we talk about the maxilla, in the maxilla variable statistics are there. Some studies say that they are more common in anterior, some studies say that equal predilection is seen in anterior and molar area. But you know, maxillary ameloblastomas, they occur in slightly older patients as compared to mandibular ameloblastomas. Now we come to the clinical presentation. It is a benign tumor, it is asymptomatic. Small tumors may be detected on radiographs. It usually presents as painless swelling and it can cause expansion of the jaws. But sometimes if it remains untreated, it can grow to very large size and it can go to massive proportions. Even then, pain and paresthesia may be uncommon. But important thing about this tumor is that it keeps on infiltrating in the bone. So it is locally invasive, destructive tumor and do not metastasize. So these two are important for your entrance. Now sometimes when tumor has thinned out the bone so much we try to palpate it digitally, this thin shell of bone may fracture. This is known as eggshell crackling. So that is your important viva question. Now important thing to remember here about maxillary ameloblastomas is they are more aggressive than mandibular. That can be your viva question. Why maxillary ameloblastomas are more aggressive? Because of the higher percentage of cancellous bone, porous bone, which facilitates faster spread of the tumor. It can spread to brain, it can go to orbital cavity, it can go to nasal cavity, whereas in mandibular, the dense cortical plates will limit the expansion of the tumor. Now we come to the radiographic features. It is a tumor which is growing inside the bones, so it is going to cause radiolucency. So classically, it presents as multilocular radiolucency. Multiple locules, multiple compartments are seen. These compartments are produced by the bony septum. So if these locules are small, we call it honeycomb appearance. But if these locules are big, large, like soap bubble, so we call it soap bubble appearance. And the borders may be scalloped. That is like this. The borders of the radiolucency may be corticated, scalloping, irregular scalloping may be seen. And sometimes when it presents as unilocular radiolucency, there are no compartments are seen and the margins may be smooth. Now on radiograph, we can also see the buccolingual cortical expansion of the bone, and even it can cause a resorption of the roots of the teeth. Now, important feature which has seen here is the resorption of the roots which is caused by ameloblastoma is said to be knife edge resorption. That can be important for your entrance. Knife edge resorption of the roots can be caused by ameloblastoma. It can also cause the displacement of the roots. Now, we have to talk about the differential diagnosis. Radiographically, when it is multilocular, it can resemble multilocular odontogenic keratocyst. It can also resemble other odontogenic tumor, that is odontogenic myxoma. It can also resemble central giant cell granuloma. But when it is unilocular and it is lying close to an unerupted tooth, yes, it can resemble dentigerous cyst. Also, it can resemble unilocular odontogenic keratocyst or other odontogenic cyst, that is calcifying odontogenic cyst. So those can be the radiographic differential diagnosis. Now we come to the histopathology. Now here we are going to talk the two components, that is epithelial component and connective tissue component. First, the epithelial component, which is the proliferating components. It may be present in the form of islands like group of cells, or in the form of thread-like structures, or in the form of cords. Now sometimes we can see small rounded extensions coming out, budding out from these islands, and this will look similar to the stages of the tooth development, and the enamel organ shows budding. So it recapitulates the stages of the enamel organ. It looks similar to that. So if we magnify this area and we look inside the island, the peripheral cells of these islands will appear as tall columnar cells, and they look similar to ameloblast cells of the enamel organ. So they are known as peripheral cells which are tall columnar ameloblast like cells. ameloblast के जैसे हैं, and their nuclei are hyperchromatic, that is dark staining nuclei, and all these nuclei are placed away from the basement membrane, that is called reverse polarity, reverse opposite pole पे पड़े हुए हैं, and all the nuclei are in the adjacent cells are at the same position, same level, that is called the palisading pattern. And if we look at the central cells, they are loosely placed cells, they are polyhedral, and these cells resemble the stellate reticulum of enamel organ. So these are called central cells, stellate reticulum like cells. Now if we talk about the connective tissue component, the connective tissue between these epithelial islands or the cords or the strands is made up of collagenous fibrous stroma. But this epithelium is proliferating. It can have inductive effect on the connective tissue, but connective tissue is not responding. It is not giving any signal. So because of which the proliferating epithelium is giving inductive effect on connective tissue, we can see a zone of hyalinization. So a hyalinized area may be seen next to the epithelium. A glassy homogeneous pink area may be seen here because of the inductive effect of the epithelium on connective tissue. Connective tissue is not able to respond back, so there is no formation of odontoblast. Dentin blockade happens, because of which there is zone of hyalinization. So that can be your viva question. Now we come to the histopathological types. These components, the epithelial component, may be arranged in different ways. So based on which we give 6 histopath types, which are also known as 6 variants or 6 subtypes of the ameloblast histopath types. So first we are going to talk about the follicular type. Now it is the most common type. It is also known as the simple type, and it is the most recurrent type. So now in this, the epithelial component is arranged in discrete islands in which we can see two types of cells, that is peripheral cells, which are tall columnar ameloblast like cells with all the features of nuclei, that is nuclear hyperchromatism, palisading arrangement of nuclei, and reverse polarity of the nuclei. So these are the peripheral tall columnar ameloblast like cells. Then in the center we have loosely placed polyhedral cells which looks similar to stellate reticulum like cells. So central stellate reticulum like cell. Now surrounding these islands will be collagenous stroma, that is made up of collagen fibers and the fibroblast cells, and there can be blood vessels. Now sometimes within these islands the central cells may degenerate, they may break down, and there may be formation of cystic cavity inside the center. So that is called cystic degeneration. So it is very common in this type. So cystic degeneration in follicular type occurs within the ameloblastomatous follicle के अंदर, island के अंदर, उसके center में होती है, because of which the peripheral cells may become flattened. So that is important point. Next we come to the plexiform type. Now in this, the odontogenic epithelium is arranged in long strands or cords, and these are interconnected. They are anastomosing, they are connected to each other. So in this, the strands are bound by the tall columnar ameloblast like cells, and between these ameloblast like cells in some places we can see stellate reticulum, but it is not prominent, it is less prominent क्योंकि space ही नहीं है उनके बीच में. So the important thing that here you have to remember that cystic degeneration can occur here also, but here it occurs in the connective कनेक्टिव टिश्यू इन स्ट्रैंड्स के बीच में पड़ा है तो वहाँ पे सिस्टिक डीजनरेशन हो सकता है. सो हियर वी सी स्ट्रोमल डीजनरेशन, वेरी वेरी इंपॉर्टेंट पॉइंट एंड वाइवा क्वेश्चन. इन प्लेक्सिफॉर्म it is stromal degeneration, in follicular it is within the follicles, within the epithelial component. So that is important. Now another thing is it is the second most common type of histopath type of ameloblastoma. Now we talk about the acanthomatous. Acanthomatous looks similar to follicular type. The only difference is the central stellate reticulum like cells, they undergo squamous metaplasia. That means they change into the squamous cells in the center, and these squamous cells will lay down keratin here, and sometimes even keratin pearls may be seen. So histopathologically this may look similar to the squamous cells of squamous cell carcinoma or squamous odontogenic tumor. So those can be the histopath differential diagnosis. Now we come to the fourth type, that is granular cell type. Now within the follicles the central cells will show granular cell change, that is they will show eosinophilic cytoplasm, and these cells will be filled with the granules. Now these granules are said to be, through ultrastructural studies it has been seen that they are lysosomal aggregates. Now that can be your viva question. What are these granules? These are lysosomal aggregates because of which this tumor is very aggressive, it can spread. So that is another viva question. So it is the most aggressive histopath type of ameloblastoma. So that is granular cell ameloblastoma. Granular cell change can even extend to the peripheral cells. Now we talk about the basal cell. In this small nests of the cells are seen, but the central stellate reticulum cells are not seen. All the cells look similar to basal cells, so they are called basaloid cells. So they can be present in the form of nest or they can be present in the sheets. Now these cells can look histopathologically similar to the cells of basal cell carcinoma. So that can be the histopath differential diagnosis. Now important point to remember about basal cell type is that it is the least common type. That can be your viva question, that what is the least, which is the least common type or the rarest histopath type is basal cell type. Now we come to the last and the important type, that is desmoplastic, जिसके बारे में हमने बोला था इसको अलग नाम दिया गया है. Why? Because desmoplasia means fibrous. So in this there is thick connective tissue, there is lot of collagen fiber formation, because of which the odontogenic component, the odontogenic epithelium hai, it becomes compressed because of lot of collagen fiber. The area seems hyalinized, एकदम ऐसे pink appearance दिखता है, and cells are very less. So there is compression, compressed odontogenic epithelial islands. That can be your entrance question. Where you see compressed odontogenic epithelial islands, it is seen in desmoplastic ameloblastoma. And these odontogenic epithelial islands, they are in the form of strands, thin cords or strands. They are not actually forming islands. The peripheral cells may be cuboidal, and we cannot make out the central cells. We cannot see the central cells here. So this is said to have flying kite appearance or kite tail. That is important for your entrance exam. Now why we are saying it is different from the other tumors and it is given separate? Because histopathologically we have seen that it is different from the other. There is a lot of collagen formation, and it is said that it is growth factor beta which is responsible for so much of fiber formation here. Graphically we see in this tumor, because there are a lot of fibers within the fibers there can be osseous metaplasia, and these areas on radiograph can look like radiopaque, less white areas. So on radiographs this tumor can give mixed radiolucent and radioopaque appearance. Now this is something similar to an appearance which is given by fibroosseous lesions of the bone. These are the lesions of the bone which can also give mixed radiolucent radiopaque lesion, and that can be your important entrance question. That is radiographic differential diagnosis of desmoplastic ameloblastoma is fibroosseous lesion. So radiographically be different हुआ, histopathologically be different हुआ. Now we look at the clinical features. Clinically the most common site for this tumor is maxillary anterior region. For all other types of ameloblastoma, mandibular posterior region is the most common, but for this it is maxillary anterior region. So this tumor is clinically, pathologically as well as radiographically different. So it is given as a separate type of ameloblastoma. Now we come to certain new types. Hybrid, when we can see two components, two types in the histopathology, that is sometimes we can see desmoplastic ameloblastoma with follicular and plexiform type. Then hemangiomatous, when we can see a lot of vascular component in the tumor, it is known as hemangiomatous. When we know keratoameloblastoma, when we see a cystic space in the tumor which is filled with keratin along with the solid growth of the cell. So this is referred to as keratoameloblastoma. Sometimes these cystic epithelium will grow in the form of papillary projections into the lumen. Then it is referred to as papilliferous keratoameloblastoma. And sometimes a term is given which is known as clear cell ameloblastoma, in which the cells will become clear. That is, they will not stain, they will not eosinophilic. So within the islands, the cells will appear clear. So that is clear cell ameloblastoma. Now we come to the treatment and prognosis. There is difference in opinion about the preferable method of treatment, but most important thing is complete removal. So different types of treatment have been used, like surgical excision. Majority prefer this. Then curettage has been done, but it is less desirable because some tumor cells may remain behind after curettage, and that is why highest incidence of recurrence is seen with this process, and the recurrence rate is about 50 to 90%. Then radiotherapy has been used, but it is seen that it is radio resistant. This tumor is radio resistant and this therapy is not warranted. Then resection has been done, so it is the most widely used treatment, but with this also recurrence rate can be 15%. Now important thing about ameloblastoma is that when we are trying to remove this tumor, we have to keep in mind that this is infiltrative tumor. It keeps on spreading into the bone, so we cannot see the actual margins of this tumor radiographically and clinically. So what should we do? When we are resecting the tumor, we should take at least 1 centimeter of normal margin past the radiographic limit. उसके आसपास का normal 1 centimeter tissue भी area भी निकाल देना है. So these are called safe margins. So this is done क्योंकि हमें उसके actual borders, actual margins नहीं पता है. So to make sure there is no recurrence, we remove extra 1 centimeter of normal tissue around this, normal bone around this tumor. So because of high recurrence rate, it becomes very necessary that we do long-term follow-up for this tumor. It can recur even years after the removal. Now, two important terms which you have to remember here, which you have to know here: malignant ameloblastoma and ameloblastic carcinoma. So, how do we know this? Malignant ameloblastoma, when a tumor has arisen in the jaws में बना है tumor, and then it goes to some other areas, it metastasizes. So, it is malignant. But when we look at this tumor microscopically ये हमें ameloblastoma जैसा ही दिखता है. उसके अंदर cells के अंदर changes नहीं है. So, that is malignant ameloblastoma. But if माइक्रोस्कोपिकली हिस्टोपैथोलॉजिकली अगर हम ट्यूमर के अंदर चेंजेस देखें, दैट मीन्स उसके कुछ सेल्स छोटे हैं, कुछ बड़े हैं, न्यूक्लियस की पोजीशन भी डिफरेंट हो गई है. सो इफ वी सी साइटोलॉजिकल एटिपिया माइक्रोस्कोपिकली, then it is referred to as amelobllastic carcinoma. So if in primary tumor, metastatic deposit, or even in the recurrent tumor, we see the carcinomatous changes histopathologically or microscopically, then we refer to it to as ameloblastic carcinoma. Now we come to the summary of ameloblastoma. So it is the second most common odontogenic tumor after the odontomas. Then the term ameloblastoma was given by Churchill in the year 1934. Other name for this tumor is adamantinoma. Then if we talk about the definition, then Robinson gave a definition according to which it is uniac, that is unicentric, non-functional, intermittent in growth, anatomically benign. Then in pathogenesis, there are 5 origins. First can be the cell rest of Malassez or cell rest of Serre. Second is from the epithelial lining of odontogenic cysts like Dento'ZEN. Third is disturbances in the developing enamel organ. Fourth is the basal cells of the surface epithelium, and fifth can be the heterotopic epithelium. Then if we talk about the clinical types, 3 clinical types are there. First one is the multicystic or solid type, which is the most common type. Then the second one is unicystic type. Then the third one is peripheral type or extraosseous type. And the fourth type that has been added is desmoplastic type. Then we talked about clinical features. The age, the average age is 33 years. Gender, male is to female ratio is same. Then side, posterior mandible is the most common site. Then we talked about the clinical presentation. It is slowly growing tumor, but it can cause local invasion and it do not metastasize, and it can show eggshell crackling. Then we talked about the radiographic features. Classically, it presents as multilocular radiolucency, can be honeycomb or it can be soap bubble. And here the differential diagnosis is multilocular OKC. And when it presents as unilocular radiolucency, it can be confused with dendrogenesis or unilocular OKC. Then we talked about the histopathology. There are 6 histopath types. Follicular, the most common type. Simple type, the most recurrent type. and then the plexiform, that is the second most common type, then acanthomatous, in which squamous metaplasia takes place, granular cell type, the most aggressive type, basal cell type, the least common type, and desmoplastic type, in which there is a lot of collagen fiber formation. Then we talked about treatment and prognosis. Surgical excision has to be done with wide margins, safe margins should be taken, and long-term follow-up is required because it has high recurrence rate. So that is all about ameloblastoma. I hope you understood the video. If you really liked the video, do give a thumbs up. Keep watching Dento'ZEN, keep following, keep reading. So good luck for your exams. See you in the next video. Till then, take care. Bye bye.